Good morning and welcome everybody to this week's seminar. My name is Mai Krishnasamy. I'm the Professor of Cancer Nursing at the University of Melbourne. And before going any further, I would like to acknowledge the Wurundjeri people of the Kulin Nations, the traditional custodians of the land on which we're based, and pay respect to their elders, past, present and emerging. So it is my pleasure to be introducing Professor Sue Evans today, but just before I do that, I'll just tell you a little about my research group, as we do in these seminars to keep each other informed. So I head up the Cancer Nursing Research Group as part of the UMCCR. As a group, we're really focused our research on understanding the experiences of people affected by cancer, so that we can develop with them new ways of organising care and new supportive care interventions that help people not only have the best experience of care, but obviously ultimately have the best outcomes from the clinical care that they have. Our work falls predominantly within a health services research framework, and we use a range of designs, mixed methods, qualitative and quantitative, but really are guided by the issues that we hear from patients in the system about what they need to be able to help them respond, manage and cope with not just a diagnosis of cancer, but the impact of treatments that come with them, whether during the acute phase of their treatment or on into survivorship. So, and that's a little bit about me and my group, but my real pleasure this morning is to introduce Professor Sue Evans. So Sue is the director of the Victorian Cancer Registry. She's an epidemiologist and a public health researcher. And for the past 10 years, her focus really has been on developing clinical quality registries to provide a rich data set from which to measure quality of care. So at the Victorian Cancer Registry, Sue oversees capture, coding, storage and dissemination of cancer data in Victoria, and works with national and international cancer and government agencies to improve capture of a standardised cancer data set. Sue is keen to ensure that data are used responsibly and actively to measure and improve the quality of care provided to patients diagnosed with cancer. And it's my real pleasure to hand over to Sue now, who's going to talk to us this morning about fast track notification of cancer to the VCR using ePath to provide timely cancer statistics. Sue, welcome.
Thank you so much, Mai. Thanks for the invitation. I'm delighted to be here. I will begin by running through an overview of what I'll discuss, and then we'll hop straight into it. So this is an overview of the content I'll be covering in the next 25 minutes. I'll begin with a brief history of the Victorian Registry, then explain how the data are transmitted to the registry and the systems we use to code the cancer information. Most of my presentation will focus on data which we are producing to inform clinicians and government on cancer activity over the past few months. The World Health Organization defines a cancer registry as a place where information relating to cancer patients, including their treatment and follow-up, is collected, recorded and analysed. This is a timeline on the establishment of the Victorian Cancer Registry. Alongside the Connecticut Tumor Registry in the US, the Victorian Cancer Registry is one of the oldest continually operating registries in the world. Other registries were established earlier, in fact as early as 1904, but have been interrupted by world wars. The Victorian Cancer Registry captured its first patient diagnosed with cancer in 1940. Was set up then by the Anti-Cancer Council and was established as a voluntary registry capturing data from 6 metropolitan hospitals. The 1981 Cancer Act, it was established actually in 1958 to outline the role and governance of the registry, but it was amended in 1981 to mandate or require cancer to be reported in Victoria. Fast forward to 2014, when the Improving Cancer Act of 2014 repealed the Cancer Act. It transitioned the registry from the Anti-Cancer Council to the Secretary of the Health Department as the authorising agency, but the Cancer Registry is the mechanism for collecting the cancer data. The regulations published soon after the Act set out the data to be collected by hospitals and pathology laboratories. Currently, cancer diagnosed by radiology centres is not required to be reported to the Victorian Cancer Registry. However, for radiology services operating in hospitals such as Peter Mac, these cancers are captured through the hospital notification provision. Australia has been categorised by the International Agency for Research on Cancer as a high-quality population-based cancer registry. In Australia, each state has its own cancer registry. The AIHW amalgamates cancer data from each state-based cancer registry. The Victorian Cancer Registry produces its annual report for the previous 12-month period within 12 months of the previous reporting year. So in other words, we'll be reporting on our 2019 cancer year in November of 2020. This is the fastest of any registry globally. This is a photo of the first page of the Victorian Cancer Registry. The first notification, as I mentioned, is recorded in 1940. Registrars would follow up health status of patients through review of hospital records and by door knocking on homes of patients diagnosed with cancer. In 1982, the Victorian Cancer Registry captured data electronically. We generally report trends back to 1982. The registry has electronically captured over 1.3 million patients and stores over 3.2 million source records. Today, the Victorian Cancer Registry captures the vast majority of its data electronically from hospitals and pathology labs. 14 medical coders in the Victorian Cancer Registry review the notifications and code each cancer report. Sophisticated statistical programs are used to merge cancer documents or reports into consolidated patient records. As this is a lifelong journey, it may be that Victorians have multiple cancers throughout their lifetime. Linkage with data from the Victorian Registry of Births, Deaths and Marriages is undertaken monthly to ensure that the registry captures contemporary statistics on cancer incidence and mortality. Twice a year, linkage is also undertaken with the National Death Index to capture interstate deaths. In August this year, the VCR will go to a new way of collecting data in a system called Abrevio. Abrevio uses artificial intelligence to abstract data from freetext pathology reports. It sorts reports into tumour streams and assists the coder to consolidate each document into a patient record. This will provide us with unprecedented ability to capture information from reports which has not previously been captured by the registry. For example, it allows us to identify the type of biopsy, the pathological stage, biomarkers, and more than 100 data fields which were previously either manually entered by coders or not captured at all. It'll also enable us to fast-track patients with particular profiles to clinical trials. You can probably imagine that there may be particular biomarkers and age groups of patients that might be eligible for a clinical trial, and the system itself will flag those particular attributes and can send notification through to particular people within hospitals for them to do case review and identify whether patients are actually eligible for the clinical trial. So we think that this is going to be a really terrific way of improving recruitment to clinical trials, which we know at the moment is suboptimal. I'm now going to tell you a little bit about EPATH. This is how we provide data to the different agencies at the moment in a fast-track sense. As I mentioned previously, pathology labs are mandated to report to the Victorian Cancer Registry. EPATH is an automated pathology reporting system which identifies cancer reports from laboratory information systems and sends them to the Victorian Cancer Registry. Currently, EPATH transfers data to a database in the VCR called VCREN. In August, it will move across to our new Abrevio system. As soon as the report is signed off by a pathologist in a lab, EPATH a system at the back end of each lab will send this information through. Currently, 94% of all pathology in Victoria is submitted using EPATH. And you can see on the right side of the screen the laboratories that contribute to EPATH. EPATH's got a very high level of sensitivity. It picks up almost all cancers. And over the last 12 months, there's been a lot of work done to improve the specificity, just so that it doesn't send us through reports it doesn't need to. And that has had some implication for the reporting that we've been able to do or that we've done to the government and to agencies during this COVID time. I'll explain a little bit about that in a minute. So data from the laboratory information system is first transmitted to the EPATH monitoring console in the VCR. I'm going to now provide you with some data from the period January the 6th, 2020 until the week ending the 14th of June. And to account for public holidays, we report on the average daily count. All notifications are received within 1 week were compared over this time period. Actually, I'm going to go back, sorry, I've missed a slide. So this is how it actually happens. The data from the laboratory is transmitted to the EPATH monitoring console. And this occurs as soon as it's signed off by the pathologist. After a period of 5 weeks, which allows time for as much data as we can get from many other sources, it's moved into the VCCC system, which will be Abrevio. VCCC database allows for more details of the pathology report to be examined. But at this stage, it's not yet consolidated into a patient record and has not been reviewed by the medical coders. So data that we're reporting in this presentation have not yet been reviewed by our medical coders. They're finalising at the moment the December 2019 data. So as I mentioned, this is the data that comes from the EPATH monitoring console and is the most contemporary data available at the moment in Victoria on cancer pathology activity at a state level. You can see that there has been a downward trend in the notification of cancer by pathology labs since the start of the COVID lockdowns. You'll see also that there are 2 grey bars in the middle there. They really just represent one laboratory where the feed from EPATH has been delayed. And so we've used the previous 10-week average for those 2 weeks. It's been fixed, but as yet we haven't yet reconsolidated those 2 weeks of data. So that's why they're presented in grey. So I'll run through a little bit about the limitations of this data before I go on and report a little bit by cancer stream. As I say, there's been a delay with getting data for 2 weeks and that's not yet been resolved. As I mentioned earlier, the data has not yet gone through a quality control or been reviewed by the coders. And the result that I presented on these slides is really just to give an indication of pathology activity, not of cancer incidence. There are often multiple sources of records that are associated with each cancer diagnosis. And of course, these include not just new cancer diagnoses, but also give an indication of follow-up pathology also taken. So I'm now going to provide some data that comes from our VCCC database, which will be our Abrevio database. But you can see that it's not quite as contemporary. This will report on data from the 6th of January until the end of the week ending the 17th of May. And again, it hasn't yet been reviewed by our coders, but it does give a much more granular detail of the breakdown of the cancers that we are receiving from the pathology labs. As I mentioned, it sits on the monitoring console for 5 weeks before it's moved in. So you can see what I'm going to present to you now will not be those last 4 weeks, but will report up until the red line there. So this is how I'm going to report the data. There are some black dots at the top of the screen, and they are dots on activity that is happening in the laboratory on weekdays. The grey down the bottom represents the activity that's happening in laboratories over the weekend and public holidays. The three grey vertical lines represent different time points between that journey from January to May. The first one is the March 12th, which was when the WHO declared a pandemic. The next one a little further along to the right is March 16th, which was when Victoria declared its state of emergency. And then the one a little bit further along still is March 30, when Victoria went into level 3 lockdown. I'm also going to present this data using some trend lines, 3 different trend lines, and I'll run through those now. This is a Poisson regression line with confidence intervals, which gives some sort of trend to our data for that period with confidence around it. As well as that, we've also got the green line that overlays it, which is a way of providing some smoothing to the data. So we'll present it with that green line as well. And finally, we'll present the data using a broken stick or a segmented regression line as well. So before we present this data, and we have presented this to clinical groups in the past, we've asked them to come back to us with answers to these questions. Does the data feel right? Where should we be focusing our efforts if we're going to then fast track the coding of incidence data to really look at the interaction between the notifications and the incidents? And we've also given the clinical groups advice that we currently within the Victorian Cancer Registry capture stage data for a limited number of cancers, and they are breast, prostate, colorectal, melanoma and lung, but we don't have complete capture of lung because there's often not pathology that goes alongside it. And I'll give you the some of the feedback that we've had from those clinical groups at the end of this presentation. So what I've got here is slide 1 of 2, which provides an overview of the trends in pathology notification by tumour stream over this time period. We start at the top left with the hematological tumours, and you can see that there has been a drop-off, quite variable across a number of the different cancers. The y-axis provides details on the number of notifications. So you can see that there are more hematological cancers that we receive compared to, say, the gynecological cancers, which is down in the bottom right-hand side of your screen, where we're getting 20 cases per week, so on average. So so you can see here that the trend generally has dropped off over these last few months, but there does seem to be perhaps a little bit of kickback activity, which indicates perhaps that slight return that we were seeing in the earlier data I presented from the monitoring console. Here are some trends that look at some of the lower volume tumours still. So of course, wider confidence intervals when we have fewer tumours and a much more scattered looking plot. So, lots of variability here. So a little bit hard to make any overall assumptions on what's happening with some of these lower volume cancers, like certainly upper GI and thyroid. We then looked at what's happening using the EPATH monitoring console with notifications over these past few weeks by the age groups of the cancer cases that we're receiving. And you can see that probably the most obvious is the over 80s, but there's drop off across the board that we're noticing in Victoria. We also thought it would be interesting to look at what's happening with pathology notifications by remoteness. So we looked at it by the integrated cancer services, which I'm not presenting today, but also by where people are located. So whether they're coming from major cities, from the inner regional area of Victoria, or the outer regional or remote area. And you can see that the numbers again drop off as we move from major city to inner regional and out to the outer remote area. And that's certainly visible in the way in which the scatter plots are displayed. But we are seeing certainly a much more significant drop off in pathology notifications in the major cities. We've also looked at the pathology notifications during this period by socioeconomic status, and we do that by using the socioeconomic index for areas at a SA1 level. So an SA1 level is about 100 houses in a geographic region. It's the lowest level that we can report on. So it's a reasonably robust way of looking at socioeconomic status, but clearly it's not down to the patient level. But it does give us a little bit of an indication of what's happening across the different socioeconomic groups. So you can see one on the far left-hand side of the screen is the most disadvantaged groups, moving through 2, 3, 4 to 5, which is the least disadvantaged or the most advantaged socioeconomic group. So having presented this data to our clinical networks over the past week, we've had feedback from many, and the overwhelming response is that it does feel right. It does feel like what's happening within the clinical practice as well. There have been some questions about whether we can report seasonal trends, particularly for cancers such as melanoma, where we know that there is seasonality. But unfortunately, because the EPATH monitoring console is new, and in that first year, a lot of work was done to improve the specificity, which is what I was talking about earlier, to reduce the noise that we're getting through that are not cancer cases. That has proven to be our worst enemy at this stage, because we can't look at historical data going back beyond the 1st of January. So that's something that we are looking at marrying alongside the incidence data for the last few years, and we will be providing that to the clinical networks in the coming weeks. We also asked the networks which cancer stream we should be looking at fast tracking to look at the incidence for. And there's certainly some appeal for cancers which have got poor median survival, such as lung, brain, CNS, to see more immediate impact of perhaps restricted access to general practice, perhaps people's not wanting to seek medical assistance with symptoms, and that would certainly give perhaps a more immediate impact, but they would the other argument is that we should be looking also at screening cancers, because we know that breast screen cancer closed their services in March, and it would certainly be good to follow those up over the next few years to see what impact that has had on stage migration. And also, of course, another request is to focus on cancers where we already have good stage data, so that we can really examine that stage migration. So I am very keen to get feedback from a wide community on where we should be really trying to move quickly to understand the impact of COVID on cancer services. Our next steps are that we will continue to report this activity, because I think it does provide a canary in the coal mine. I think it does give us an indication of what's happening in the community, and it's certainly the most timely data that we have in Victoria at the moment. fast-track cancer certain diagnoses we will do to understand the impact on cancer diagnoses and mortality. And we will work with the clinical community to identify where we should start. We're also very, very keen in the Cancer Registry to undertake research with our research community, and we've certainly had some interest by a number of craft and specialty groups to do some work to look at this, their cancer stream in more detail. So I'd like to acknowledge the team that sits behind me and certainly is incredibly supportive. Luke, who has headed the analysis of the data, and he has been working very closely with Rory Wolf, who is a professor of statistics at Monash University. Louis is our electronic notification coordinator who downloads and provides the data to us. Chris Ivanova oversees the data quality. Catherine and Fiona oversee all things EPATH, and of course the wider VCR team who are coders who get the work done and make all this possible. I'm very happy to take questions, and if you would like to reach out and do some research, then please do get in touch with me. My emails are there and my mobile phone number is there as well. And obviously I'd like to acknowledge the Victorian Department of Human Services who fund our registry, and also all the work that's being done on Abrevio to bring forward some real advancements in Victoria that I think will see us really leading the world. So thank you, Mai.
Thank you, Sue. Thank you for a fantastic talk. I mean, what a remarkable opportunity for us as Victorians and nationally more broadly. Just to encourage people, if you have questions, please put them up either through the Q&A panel or into the chat. I'm sure there's lots of things, Sue, that people will want to ask about. There is one question that we have up already through the chat, and I'll present that, and a couple coming in. So there's a question here. I'm just going to move you and me around, from Martin, saying, thank you, Sue, great presentation. And Martin's asking, can you confirm if the decline in cancer notifications in Victoria is equal or less compared to other countries more affected by COVID? And when do you expect that stage information to be available?
Yeah, so look, it's hard to tell how we are comparing with other countries. Certainly Netherlands has produced some papers, which I can certainly share the links to those papers with those interested, but they have certainly seen a decline of about 30 to 40% in their cancer diagnoses. We can't talk to the diagnoses at the moment, but we are certainly seeing a 30% decline in notifications pretty much across the board. So, so I think that if the notifications translate to diagnoses, then we are likely to see a similar trend to the Netherlands, but time will tell. The other question was around the...
Jake was saying, again, thanking you for an interesting talk, and saying, what coding system is used by the coders at the VCR?
So we use the coding system. The hospitals will all code using ICD-10, and we capture the coding system, the data from ICD-10. And we're also coding ICD-03 in the cancers for the pathology. And we stage according to the AJCC, which is the American Journal, a Joint Committee on Cancer staging system, which at the moment is on the 8th version.
Okay, thank you, Sam. I just want to go back before going on to another question from Michael. Martin's just put a prompt in, just asking for that piece of information about when you might expect stage information to be available.
Sure. So at the moment, if we don't fast track, at the moment, our coders are finalising the 2019 incidence year. They're at the very end of December. There's a little bit of QA and they'll start January in the next 2 weeks. So we anticipate that we'll get stage data for March in September. So if it's not fast tracked. If there are particular cancers that we can fast track, we will move our coders to doing that, and we can start that as soon as next week. But at the moment, yeah, September will be when we start to get to March.
Great, thanks, Sue. Question here from Michael saying, how is the registry coping with change in T&M stage classification to ensure the classification is as accurate as possible? And then the second part of the question is there a focus on ensuring survival data is updated as often as feasible?
So we have a QA manager, Chris, who is absolutely amazing and right across the T&M changes with every tumour stream. We obviously are coding our stage according to the most recent classification system, but we are also very much relying on the pathology labs. And if the pathology labs are using older staging systems, then we are bound by that. So that is always a challenge. We do capture and update our survival data, as I mentioned at the very beginning of the presentation, monthly. So we have very good data, very timely, up-to-date data as it comes to us from the Victorian Registry for Births, Deaths and Marriages. But we are only merging twice a year with the National Death Index. So where deaths occur outside of Victoria, they will take a little bit longer for us to receive them and to embed them into the registry. But for anything else, we are getting very timely data.
Right. So just a clarification from Michael, they're saying, so there's no backward correction. That is that those that diagnose, say, on T&M 7th edition, that doesn't get reclassified?
No.
No. Okay.
No, it does not.
Okay.
Yeah.
Thanks,
Michael. Sorry, you're right.
And then a question has come in asking, are other state cancer registries doing some, the same sort of thing?
Not that I'm aware of. We've certainly been reaching out to them. I mean, to be honest, most other jurisdictions are well behind Victoria in coding. Most other cancer registries are really on 2017, 2018 data. As I mentioned at the start, we are really leading the world in timely coding of our data. So it wouldn't be possible for other jurisdictions at the moment to do what we're able to do in Victoria.
Yeah. Just sort of for me, so just thinking about that data that you were talking about, and obviously some of the data that you've been feeding in around the impacts of COVID, and wondering more at a policy level about how this information is then used perhaps around prioritising services into the next 3, 5, goodness even knows 10 years. I'm just thinking about what some of those conversations have been.
Yeah, sure. So we present this data each fortnight to the task force, the VCCC and the Monash Partners CCC network meeting, which is held every second Tuesday. And that then is distributed amongst the clinical groups, which is where we've been able to get some feedback on, whether it feels right and what we should be doing next. The data are also circulated to the health department and through to the health minister. So it is being looked at. And there are a number of different, I can't even, I'm not even sure what the acronyms are for a lot of these communities, but CLEG is a committee that's within the health department that is a clinical leaders network as well, exec network, I think. So we're also providing data to that group as well. So it certainly is getting widely distributed. I think that there will be, it's very difficult times, isn't it? We're saying, people with cancer should be seeking, medical treatment and see their GP, but, then we get announcements like yesterday where people should be staying at home, not going out. And so, I think the community are rightfully, worried and perhaps even a little bit confused. So I think there is a lot of media coming out over the next few days and certainly weeks from interest groups to try and really highlight that people who are symptomatic really should be should be seeing their GP, and certainly Breast Screen and other agencies are doing a lot of work to do better risk adjustment, or identify patients at high risk and prioritise those through the screening system, because they're having to halve their numbers of patients seen each week because of the cleaning and the things that now need to take place. So that certainly the data are being shared, and there will be stronger messaging that will come out, I'm sure, in the next week.
Yeah, great. Thank you, Sue. I've got what is probably a fairly simple question. One of the things when you were talking about, the incredible opportunity around flagging patients for trials, I'm just wondering, how do you, as the VCR, keep a track of what trials are open, what's available, what's where?
Yeah, look, that is such a good question. You'd think it would be an easy one, wouldn't you? No, it's not. I know, the CCV has a list of clinical trials that are open at the moment. When Abrevio goes live, I think that we will reach out to particular trials that we know are open and let them know that, this is a service that we may be able to help them with. In the early stages, Abrevio will need to be bedded down, so it may flag cases that end up not being appropriate because of the auto extraction, because the fact that it is reading the text and putting it in to fields, and then using that as sort of the flag to send the email off to highlight a potential case. So it will take a little bit of time to bed that down, but we think it's going to be really powerful, and I think it'll be a matter perhaps of clinical trials groups reaching out to us as well, and to saying we'd like to register patients, and we'll give them the list of the variables that we can flag a patient by, and then we'll be able to work from that basis. But in the early stages, we wouldn't want to do it for all clinical trials. It just needs a bit of time to kind of be bedded down and tested. But in the future, I think as more clinical trials come on, a better way of registering will need to be sort of worked through.
Yeah, fantastic. Thank you, Sue. Thank you very much for a fascinating talk. I think everybody's going to be looking forward to seeing what comes with Abrevio and the other work. And, again, just really flagging how incredibly fortunate we are in Victoria to have you and the team leading that work, and the opportunity it creates, for us as clinicians, researchers, and obviously for the patients in their care. So thank you very, very much.